welcome to this conversation on the role of norepinephrine as a common treatment target. Now, you will like this slide as much as I've loved it for actually many, many years, because it reminds us norepinephrine seems to sit right at the junction of three different pathologies our patients with various disorders have. For example, limbic hyperactivity. That is very common in our patients. As a result, patients have excessive and negative emotions. But we also have dorsolateral cortical dysfunction, so different part of the brain. And this overall tends to be underperforming, which then leads to individuals not being able to mount a defense against their excess emotion by using cognition and rationalization. They're not able to do that. But on top of that, they have challenges with a dampening of the pleasure circuit. They're not able to appropriately feel joyful or happy or content. These all three come together, and norepinephrine appears to sit right in the middle. Norepinephrine abnormalities in disease create troubles all over. But this model of looking at things also reminds us why cognitive behavior therapy and positive activity interventions are at the center of all norepinephrine-related interventions. And pharmacotherapy can play a very important role, but pharmacotherapy thought out correctly and well in case we need further help. And in some patients, we absolutely need all three of them. But this very beautiful illustration reminds us of at least two or three things of great importance. Number one, our patients who have psychiatric diseases tend to have multitudes of difficulties. As you can see, there's three different. Point number two, these difficulties appear to be different in different parts of the brain. It could be too much activity or too little activity coming together to create the pathology. And the third thing you should remember is if we want to correct this, we're going to have to think differently, not just in terms of too much or too little, but appropriate modulation. So here we go. Look at sleep hygiene, which is a remarkably important and interesting non-pharmacologic intervention that does have pretty significant positive impacts on norepinephrine dysfunction. So if you think about the disorders that we just discussed, major depression, we talked about PTSD, we talked about agitation and Alzheimer's disease, and many other disorders, sleep disruption of all kinds are quite common. Certainly pharmacotherapy is appropriate in many of these patients, but I think so is sleep hygiene. In fact, sleep hygiene ought to be the first intervention, not just because it's effective, which it is, but also sleep hygiene can modulate the tone of norepinephrine so that the patient's needs are served better. Sleep is very important. Of course, pharmacologic modulation can be very useful, and let's talk a little bit about that. So before, the only real way we could go after norepinephrine was through SNRIs, so serotonin norepinephrine reuptake inhibitors, and we've had some mixed results because when you do reuptake inhibition of any neurotransmitter, you're not really targeting any particular receptor. What you're doing is broadly increasing and changing one particular neurotransmitter, which may or may not be effective. As a result, as you look at the second bucket here, you will see that there are other pharmacological targets we should consider. Previously, we have talked quite a bit about the alpha-1 and alpha-2 families. We've also talked about beta, and guess what? In anxiety difficulties, in norepinephrine difficulties, there is a role for beta-1 blockers, but the problem is it's a limited role. It generally speaking helps primarily with the cardiovascular overreactivity and doesn't have great impact on, if you will, central symptoms of norepinephrine abnormalities. And the same has been true with alpha-1 blockers or alpha-1 modulators. The trouble there is, well, we're able to suppress nightmares, but we're not able to do much more than that in such patients who have evidence of norepinephrine abnormalities. You could increase sleep, but not offer a full spectrum of coverage. But there is a new class emerging, and that is the noradrenergically active atypical antipsychotics. Now, they're certainly called atypical antipsychotics because they have effects on dopamine and they have effects on serotonin. But there are some of these atypicals that tend to have significant norepinephrine receptor activity as well. And as we have learned together, sometimes it is the combination of the inhibitory and excitatory, presynaptic and postsynaptic norepinephrine receptors that leads us not in a state of decreasing or increasing norepinephrine activity, but doing both. Because I think by now we have together established quite well that patients often have both. As a result, this class of emerging therapeutics is of great interest to us. So let's look at the panel consensus, and there are 4 items I'll quickly cover with you. First is norepinephrine system dysregulation is squarely at the center of a large number of psychiatric disorders that we've already discussed. 2, norepinephrine modulation should be considered, along with others, as one of the goals of treatment. And it's really important not to fall in the trap that we used to before of these simplistic conversations of let's just decrease norepinephrine in this patient, let's just increase. Both of these approaches will most likely fail because the pathology in patients is a combination of too much and too little. That much is self-evident when you meet patients. The third is today's clinician needs to be far more thoughtful, far more astute, and to think about optimization of norepinephrine functioning. Think about pre- and post-synaptic receptors. That's the way to do it. And of course, the goals of treatment haven't changed in that our goals are to offer maximum benefit to patients with the minimum of side effects, potential side effects that a patient has to deal with. And we should also keep the fact that short-term goals are important, but long-term goals are equally important. And we should always keep in mind that holistic, complete treatment approaches that include psychoeducation, psychotherapy, wellness interventions, and if need be, pharmacotherapy, that is what's indicated in helping our patients. I really enjoyed talking with you, and I thank you very much for listening to me talk about norepinephrine.